Today's guest is Dr. Vishnu, a leading vascular surgeon and one of the founding members at Jivas, Bangalore. He specializes in complex vascular conditions, from peripheral arterial disease to aneurysms to diabetic foot and limb-saving procedures, using both advanced endovascular and open surgical approaches. Dr. Vishnu is a part of a new generation of specialists bringing world-class vascular care to India. In this episode, we will uncover why vascular health is the silent backbone of life and the simple steps we all can take to protect it. Every 3 minutes, India loses a limb today, and vascular disease is something that is so common, but most never see it coming. Why is this vascular health so ignored when literally it keeps each and every organ alive? And today we are sitting with Dr. Vishnu, a vascular surgeon who sees stories like this every single day. Dr. Vishnu, can you take us inside the operating room, the most memorable case where you realize that vascular health is the silent backbone of life?
In my last 30 years, I have seen thousands of vascular cases. I think where the biggest benefit I feel I have given personally to patients are in patients with gangrene and diabetic foot. Because I feel this is a missed segment. There's very less awareness in the population. For example, when I started my practice 30 years ago, when people used to come with gangrene, infection in the leg, etc., and they also had vascular disease, the average age group of those patients were in their 60s and 70s. Normally, when we used to give them an option that we can try and save the leg, we can do surgeries, etc., the common by default mode of thinking of the attenders used to be, we don't want to take that small risk. We would prefer having an amputation done, and we would rather have the patient with us for as long as he lives. We'll take care of him. So that time, that was a mental resistance. Now, if you look back, now the change in the last 30 years is because of information being available, because of elderly people willing to make their own decisions for themselves. Now, when patients come with ulcers, gangrene, with some vascular blood supply problems to the leg, when we offer them the standard treatment which is offered to any patient anywhere in the world, now at least 60% of them say, I am not ready, or I'm not keen on quantity of life. My priority is quality of life. And now, hence, people are more receptive to getting vascular work and getting their limbs saved. And that is a big shift. And hence, now my work is making a big difference in saving people's limbs and improving their quality of life. So that makes me very happy when I see people, old people, living an active life, being independent. I feel that has made a difference now.
Right. So now that you said gangrene and ulcer, what are the actual root cause of these diseases, Dr. Vishnu? Because it really doesn't start off at the surface level, right? It clearly starts off at a somewhere base level of an endothelial level, or at the level of the capillaries, which are like highways in our body. We have almost 6,000 miles of highways in the form of blood vessels, and then we have capillaries in the form of your service roads or side roads or whatever. So where does this actually start off? Because it's a massive system.
See, the vascular system is called the lifeline of the body. Ultimately, where blood goes, where oxygen goes, there is life. Where blood doesn't go, where oxygen doesn't go, there is no life. This process starts in your middle age. And this is when the problem is missed. And it always starts in the innermost lining of the blood vessel, which is known as the endothelium. In that, you have the intima. So all the problems start there. So it starts first with tiny breaks in the endothelium, then it starts with cholesterol deposition there, then you have inflammation, and then you have a cascading sequence of events which over decades results in permanent damage to the blood vessels. And some organs are more prone and some are less prone. For example, normally the heart, the feet, the retina, the kidneys are more prone rather than the other abdominal organs. So this process starts from the endothelium, the intima, and it progresses gradually over decades. And the problem is, because it's silent, it is missed. And then when most people who come to us in the last stage.
So it means to say that, to sum up, vascular disease isn't like an abstract sort of a thing, right? It is the reason most people have these sudden pains in the leg, because it is starting off somewhere deep in the endothelial level, and it is progressing day by day, because it is like, it is starting off at the base. If you were to take a base and then build over it, right? It is starting off at the basic level of the blood vessel, and over time it just builds up and ends up blocking this blood vessel, and that is what it is. So intima is basically the innermost layer, starts there and then goes to your media and then towards the lumen and eventually ends up blocking the lumen.
Yes, you're perfectly right. It starts always in the intima, then the inflammation, etc., spreads to the middle layer, the outer layers, and then the end result in any part of the body would be either thrombosis or occlusion and fibrosis. So the last end stage might be different in different people, but the pathology and the process is similar in all blood vessels all over the body.
Right. Now you mentioned about gangrene. What is the major cause of gangrene in today's world?
In today's world, I think the major reason for gangrene of the feet is diabetes. And diabetes basically impacts multiple areas in the feet. For example, diabetes impacts the blood vessels, diabetes of the feet, diabetes impacts the nerves of the feet, and diabetes impacts the immunity and causes a higher risk of infection. So, this triad of vascular problems, neurological problems, and infection in various combinations or in isolation is the main reason for gangrene in the feet, especially in the aging population.
So now that you said that gangrene of the feet, can you tell us that it's possibly one of the major symptoms and complications of diabetes, right?
Yes.
Because today we are seeing India has become the capital of diabetes. That conversation has moved on. People have forgotten that we are getting unhealthy day by day. But what has not moved on yet is that we're seeing more and more complications of diabetes because people refuse to take care of themselves. Is that a right statement to put across?
Yes, it is partially right in the sense that one, people refuse to take care of themselves. But the second thing we miss is, as our longevity increases, as we are living longer, like now I think the average lifespan is almost in the mid 70s. So as we are living longer, the number of people with vascular disease are increasing. So the population of people with vascular disease and diabetes is increasing. And on top of that, because of unhealthy lifestyles, the younger age group is also getting more of diabetes and more of vascular disease. So overall, the number of people with vascular, and especially the younger people, are increasing as every decade goes. And because they are increasing and lack of awareness, your complication rate also is going to dramatically increase.
Right.
So I only foresee that in the future, diabetes, vascular disease, and their related complications are only going to increase further and further. I don't see a dip unless there's a radical change in awareness.
Right. Another common question I have is that, is it just cholesterol? Is it just blood sugar or blood pressure? Or is it inflammation and endothelial dysfunction? What is it?
It's a whole combination. When you're looking at atherosclerosis, that is the whole disease gambit for vascular disease, wherein there is atherosclerosis of the blood vessels, which results in all the related problems with vascular disease. Actually, you have 8 stages of atherosclerosis. It starts from the first stage and goes on to the last, which is the 8th stage. The first one would be the fatty stage. That is cholesterol deposition within the blood vessels. Studies have shown that when you do an intravascular ultrasound, fatty streaks, that is the type 1, the first stage of atherosclerosis in the blood vessel, is actually seen in 30% of people by the age of their mid-20s. So if you catch 100 adults in their mid-20s, absolutely asymptomatic, but if you do the test, you will find that fatty streaks have already started in 25% of them.
Right.
And then this progresses gradually over years and depending on the lifestyle to the last step. So this is the trigger for everything.
So that means even before anybody knows it, that heart attack which you got in your 50s actually took place in your 20s or 30s. It is the ignorance that someone had in their 20s and 30s and what they did at that age is actually resulting in the vascular disease in their 50s.
Yeah, definitely. Always. It's always the case that when you have your either cardiac event or a leg critical event in your 50s or 60s, the actual starting point would have been in your mid 20s, 30s, and the major mistake would have happened in 40s. That is when it kind of fastens up the process, and then you have a critical event in your 50s and 60s. This is always the cause. There are very few causes wherein it's genetic, and there are other reasons wherein you can happen suddenly in your 50s. But by far, atherosclerosis always starts much earlier, and the end result is seen in your 50s, 60s, and 70s.
Another question that I have when you said that, it's only in your 50s and 60s. Now that I am a young 30-year-old, what is that I can do now to change my progression of a vascular disease in the next 10 years, 20 years? What is the thing that I can say that this is something I should test? These are the actionable steps I can take towards even preventing it or reversing it.
Reversing, I think, is not possible, but stopping it at the level it is in or preventing progression is definitely a possibility. And I think the first step is awareness. If you are aware of vascular disease, you are aware of what it can cause you decades down the lane, you can take preventive steps. So preventive steps basically are, it's been told by multiple people over decades. It's all about lifestyle, diet, and then regular testing of a few blood tests to see what stage of inflammation or lipid abnormalities are there in you, and then accordingly control that. So I would say if you can divide this into two things. One is lifestyle and dietary, and one is investigations and then medications. But I think for somebody in their 30s or 40s, the focus should be on lifestyle and dietary changes. So I think if these simple things in dietary and lifestyle are managed well, you can slow down the progression. You can't stop the progression. It's like saying there's a diabetic patient with uncontrolled diabetes and there's a diabetic patient with controlled diabetes. It does not mean that the patient with controlled diabetes for decades will not develop complications. He will develop the same complications in a milder form much later. The same holds good for vascular disease also. So in your 30s and 40s, if you have proper control on your lifestyle, diet, and do the right test, you can prevent or reduce the odds of those complications occurring much later.
Right. If you can recommend, for example, what are the tests one should do in their 30s as a preventative checkup? Because now we see that with insurance, everybody wants to get, a full body evaluation done because they've seen their parents suffer and they say that I do not want to be in this place.
This is a catch-22 situation in the sense that, like what you mentioned, I've had patients coming in asking me, or their kids coming in telling me, see, my mom or father has diabetes, this has happened, we've gotten out of the crisis. Can we do a full body checkup and make out where all the blocks are so that we can be well aware? The problem with that kind of approach is, if a patient or the family demands, I want complete knowledge, complete testing to be completely aware of the process, you have to go for the definitive tests, which are the big tests. But the problem with the big tests also, the side effects of the test, not the treatment, are also involved. So the best test to make out all blocks in the body is a form of an angiogram. Now you have three types of angiograms available. One is called a CT angiogram, one is called an MR angiogram, and one is an invasive angiogram where you are admitted to the hospital. So if you do a CT angiogram of the lower limbs, you will come to know for sure, or an MR angiogram, where all the blocks are, the percentage of blocks, all that stuff, and even the type of block. But the disadvantage is you're getting exposed to contrast agents, you're getting exposed to radiation. Even a normal CT scan of the chest, not a CT angiogram, just a normal CT scan of the chest, is said to be equivalent to 100 X-rays. So if you're planning to do a CT angiogram of multiple parts of the body, just imagine the kind of radiation exposure, just imagine the kind of dose of contrast you're exposed to. That itself has its own side effects, that itself has a risk of cancer if done very frequently. So normally we counsel patients that if you're not very symptomatic, don't go down that lane of going aggressive and doing all the required tests of the highest quality for inflammation. Do the basic tests. So when you're looking at basic tests, one thing is definitely lipid profile. So do your lipid profile, do it once in 3 months, see how you can get it under control. Getting it under complete control again is not advisable, because if you overdo it, then you'll have a rebound effect and then something else will go wrong. So make sure you gradually get it down. That is from the cholesterol point of view. The second important thing from the vascular point of view is inflammation. For inflammation, you have a small simple test called as HR-CRP. That is high sensitivity CRP test. This will give you an idea on the inflammation in your body. So track that once in 3 months and see if you can reduce the inflammation. How do you do that and how do you reduce the cholesterol? Both are lifestyle and diet related.
Right.
So I think I would recommend all people don't overdo the testing. Stick to your lipid profile, stick to your CRP, work on that and gradually reduce your inflammation and cholesterol levels. If you do that properly and it still doesn't happen, then maybe we should go in for higher level testings, like you have a panel of biomarkers for inflammation. You can do your lipid cholesterol tests in detail. You can do apolipoprotein testing. But I think that should be step 2 only if needed.
Right.
Step 1 should be only these 2.
Got it. So another thing is now, is cholesterol actually bad for you? Because there is a lot of news about, actually conflicting news about cholesterol being good for you and that you shouldn't, rapidly bring down your cholesterol levels, or you should have a base minimum level of cholesterol. Like statins are now kind of saying, as it's a pharma lobbying, that statins should no longer be prescribed. So what is your take on it?
Right now, that people are saying that controversy exists as of now in the last 2-3 years after the latest papers have come out. But from a vascular point of view, I'm not talking of a cardiac point of view. From a vascular point of view, because vascular disease is considered a disease of old age, the present recommendation anywhere in the world, even now, as of today, for vascular disease is you must take a statin. It is a must. Even if your lipid levels are under reasonable control. So for vascular disease, the thinking is contrary to what is happening in the rest of the world for other organs.
Another common thing we see here, like you said, is that vascular is different from cardiac. Now, what most people do is that they only take care of their cardiac health and think that now if I have all of my ECG, because we have been preaching a lot about it. But now I think the entire scenario, entire education has to change, that it is the vascular health that we need to be more and more concerned about, rather than just cardiovascular health, because both go hand in hand.
Hand in hand. Totally agree. Previously, when the age span used to be around 60, most people were living only to 60, 65. Most people used to pass away because of cardiac ailments.
Right.
So that is why the paranoid obsession with cardiac. Now, as people are living longer and longer and you're coming close to your 80s, from a lifespan point of view, you are seeing that most people are living beyond their cardiac event. So what do I mean by that? I mean that for every 10 patients, vascular patients I see, 8 are in their 70s and 80s. And most of these people, when I take the history, they had already had 1 or 2 heart attacks in their 50s and 60s. They had had eye problems, diabetic retinopathy. There probably a few of them will have kidney problems. Majority are diabetics. By the time they come to us for vascular, that means they've already had all the other systems. They're already damaged. So vascular is a disease of old age. It comes after cardiac and all other problems.
Right.
So now the priority for people who are living longer should be, I am through the phase of cardiac already, and now in my 70s, in the 80s, I should be aware that it is not cardiac, it is going to be vascular, which is going to cause me to suffer.
Right.
So that awareness still has to come.
Another common thing is we see a lot of patients coming with calf pain. Normally, what they would do is they'll start massaging with different kinds of oils and balms. Now, why is it that this is a similar red flag as chest pain?
It's a very, very big red flag because it's happened. I've seen dozens in my career wherein the patient comes, we had patients who come late and who actually passed away, and the history given by the attenders is simple. Patient had calf pain, slight swelling. By default, we thought we'll massage, and after massaging, immediately or within 2-3 hours, the family says patient had breathlessness. We thought it was a heart attack. We took them somewhere and gave them some treatment, but the patient passed away. But the actual story is different. If a patient had had a DVT, which was called deep vein thrombosis, that means the veins for some reason have got clotted. And then you go and massage that area, and it's like you're massaging the clot and breaking the clot, and a piece of the clot breaks, silently goes towards the lungs and the heart and gets impacted there, and the condition is called as pulmonary embolism, and this causes death. So the cause of death for this person or this patient would have been actually not because of the clot per se. It was because of the clot and the added massage which caused the clot to break and actually induced a pulmonary embolism and death. And this is, the information regarding this is very, very low in the general public. Most people think I have shortness of breath, or my relative had shortness of breath and he passed away. The default thinking is, oh, this patient had a heart attack. It was a heart problem. Probably the heart was completely normal. It was a clot in the leg which was massaged or not treated, and a piece broke, went to the heart and the lungs, caused a pulmonary embolism and sudden death.
Right.
So this awareness is not there in the people as of now.
Right. So we usually see that shortness of breath, they try to take a pause. Maybe they think that it is asthma. Most people, and most commonly or not, they think it is a cardiac attack. Right? What is one simple thing when people have calf pain, especially if they are already having multiple comorbidities like hypertension, diabetes, or if not also, that they can do once they have a calf pain?
If you have calf pain and you have shortness of breath, by default, the first line of thinking should be, is there some blood clot in the leg which has now traversed towards the heart and the lungs? And for that, the treatment is, if you are far away, the first step is you have to get a blood thinner injection near your house as soon as possible, and then immediately you go to an emergency center and get evaluated. 2-3 simple tests will be done. Those tests will tell you whether the shortness of breath is because of a cardiac event or a pulmonary event. And if it is a pulmonary event, the treatment is different.
Right.
There are various types of treatments. Depending on the type of pulmonary embolism and the grade, you have various levels of treatment. So it can start with just few blood thinners in the ward, or you have what is known as systemic thrombolysis, where you give a clot buster injection in your arm, or you have invasive thrombolysis, wherein you put a catheter into the artery in the lung and then dissolve the clot there. But that is a decision taken by the emergency team. But timing is priority, and the take-home message basically is, you have a swelling in the leg, you have discomfort, you have calf pain, and you have breathlessness. The first thing which should strike the mind of the family members is, could this be a DVT and pulmonary embolism from a clot in the leg? That should be the first thing.
Right. Another common thing we see is that even hospitals miss this. So should there be a protocol that is set up for pulmonary embolism, just like we have for stroke and we have for managing MIs, that is cardiac events?
I totally agree. The problem is, for all these decades, vascular was an unknown specialty. People never took this seriously, whether it was the patients, the public, the medical professionals. Awareness now has started creeping in. People, when it comes to heart and the brain, they take it very seriously because they feel it's very disabling and something can go wrong. That kind of awareness has not still kicked in for vascular problems of the leg. So yes, it has to be taken seriously. You need to follow protocols, and I think like how for the cardiac protocols, for the stroke protocols, wherein within 4 hours of the event, not after coming to the hospital, within 4 hours of the event, if you intervene, the results are great, patients do really well. The same thing would probably apply to even DVT and pulmonary embolism. And I think hospitals and the state should probably create uniform protocols and then start applying them. But because I think by doing that, one, you'll be saving lives, and two, you'll also be spreading awareness among the public.
Right.
So once awareness comes, if something like that happens, at least they'll come early to the hospital.
Right.
And time makes all the difference.
Yeah. So now that we spoke about implementing protocols at the hospital level so that each and every staff is aware that these symptoms are there and this is how patient will present. So what happens is the entire cascade of events is much faster because the entire team is aware of what needs to be done and how it can actually be managed and prevented. And this could be life-saving. Now, the major question that pops up to me is that should vascular screening be made more like that of how we have cardiac screening in today's world?
Yes, definitely. In the West, because vascular surgery is already an established specialty for many decades, they have a proper protocol. There is a test known as the Ankle-Brachial index. Now, when you're looking at screening, you're also looking at having a test which is reliable, which is accurate, and which can be easily done by nurses and basic general practitioners. It doesn't have to be a specialized test. For people with cardiac disease, the screening would be in the form of an ECG because it can be done anywhere, even in the rural setup by non-medical people, even trained nurses or technicians can do it. The similar equivalent for vascular is an ankle-brachial index. But probably ankle-brachial index is probably more important as a screening tool than ECG. Because if you do an ECG, it gives you information only about the heart. If you do an ankle-brachial index, also known as ABI, as a mass screening tool for senior citizens, it will give you the risk of problems in the vascular system for the legs. It will also tell you if you are a high-risk candidate for a heart attack from a cardiac point of view, and also it will give you an idea of your stroke risk. So it will give you information on multiple systems. And as I told you, vascular disease is a disease of old age. So for old people, they're already at a risk of all these three systems, and this one test is very, very useful for giving you an idea on the stroke risk, cardiac risk, and amputation risk.
With regards to, now you've told us about ankle-brachial index. That is something that everyone should ask their doctors to do once they are above 50. That's what is the takeaway from this, right?
Definitely. I think ankle-brachial index should be done annually, at least in all people after the age of 60. And why it is so important is by just doing an ankle-brachial test annually, and if it starts dropping from 1.9, if it comes beyond the critical threshold of 0.4 and below, then you know that this patient, even if he is asymptomatic to you, he is falling into a higher risk category of having a heart attack, having gangrene or ulcers in the feet, or having a stroke, and his overall mortality or risk of death is increasing compared to other patients of his age. So he is an ideal patient which you have to aggressively counsel, treat, implement preventive measures and prophylactic medications also. So this would make a huge difference to millions of patients, senior citizens, if it is done properly and correctly.
Right. Now, having said that, what would be the telltale signs or trigger signs that one would see before developing a gangrene?
Gangrene is the end point. Small signs always are there in the starting. One, you can have thinning of the hair, you can have color changes in the skin starts becoming slightly pale, temperature changes. So one leg, when you feel the temperature at the back of your hand is slightly warmer than the other leg, that shows that slowly the blood circulation is dropping. Second, if a patient says, I go for regular walks, 1 year back I used to walk 1 kilometer, now I'm walking 20 minutes. Or a patient says, when I have I have leg pains at home also, then you know something is wrong. So either if it's color change, if it's temperature change, if there is pain on walking, if there is swelling of the legs, these are all indicators that something is going wrong, maybe not serious, but it mandates that you have to meet your physician once.
Right.
The problem with vascular disease and diabetics is a lot of times these symptoms are there, like color change, pain, swelling, all that, but it can be silent. And when it is silent, unlike the younger generation, the older generation don't take it seriously. They say, I'm at home, because of age, this kind of swelling is expected, or maybe this color change is expected. Let's wait and see. When it troubles me, I'll take it seriously. And I think that is a big mistake which senior citizens do. I think there's no harm in going and meeting your family practitioner once if you get these symptoms and just get evaluated. Nobody is telling you you should have some aggressive treatment done for it.
Right.
But I think information is power. So first get evaluated so you have the information and then you can take the correct decisions.
So now if we catch the gangrene or wherever you said these symptoms at an early stage, what is the thing that we can actually do? Now we have seen that, a patient comes to you and then you see that there is a clot or there is some kind of inflammation which is blocking the vessel, and hence patient is experiencing so many symptoms. What is the single thing that we could do to actually improve their health?
It depends on the stage. For example, a patient might have a lot of blocks in the body, but sometimes by default they are well compensated with a lot of collaterals. So though the blocks look quite dangerous and quite bad, symptomatically they're not that bad. So evidence says that because our vascular patients are patients of old age, they fall automatically into a higher risk category than regular patients. Don't be too aggressive. So go more on symptoms and then on the test results. So if a patient is mildly symptomatic, not very symptomatic, then the onus should be, let us try medical management. And medical management, 2 tablets are a must for vascular disease. One is a statin and 2 is an anti-platelet. And these 2 probably for life, irrespective of your blood reports. So start the patient on these 2 tablets, assess his symptoms, see is it stabilizing or is it worsening. As the disease progresses because of aging, at least 30% of them, even if they are on the correct medications, they tend to worsen. If you feel they are worsening, then you might have to do something more, wherein you might have to go and do something to the blood vessel. That means, in layman's terms, it's like the main road is blocked, the side roads are not carrying enough traffic, so gangrene or the end problem is happening in the end stage, so I have to do something. So then you have to go and treat the main road. So for that, you have 2 modalities. One is known as endovascular, which is minimally invasive. It's not non-invasive, it's minimally invasive, that means through a needle. And the other is open surgery. Given that open surgery has higher morbidity and mortality, because it's a open surgery, there's a lot of cutting involved. Most people prefer the minimally invasive one, in which you put a wire, you do an angiogram, and then you do what is known as balloon angioplasty. And after the balloon angioplasty, in selected cases, you go and put a stent.
Right. So what I understand from this conversation is that just like your heart, you do stenting. Similarly, even your vasculature, stenting is done in cases where it is needed in order to unblock those vessels. And a balloon angioplasty basically is place wherein you put in a balloon and you make more room for the vessels, for the traffic to flow.
Exactly. There is a slight difference between the approach to endovascular interventions in cardiac versus vascular. The first 2 steps are the same. You have a roadblock, so first put a wire, try and drill across that block. Second step, put a balloon, widen the road. So those 2 are universal. The difference comes in stenting. If you ask a lot of patients or people and ask them about their experience with their relatives, people who have had heart attacks, by default, the answer is yes, He's been put 1 stent, 2 stents, 3 stents, whatever. But it's very rare for you to hear of a cardiac patient in your relative circuit or in public who says, I had a heart attack and I didn't have a stent put. It is by default put, and not 1 stent, it's always more than 1, 2, 3, etc. Why? Their stents do well because the stents are very close to the heart, and when the heart pumps with such force, the blood goes through this metal and the metal stays open. In the leg, the philosophy is opposite. Wiring and plasty with a balloon is mandatory, but stenting is very, very selective. Very selective. Normally, even if you put stents, we put it in the area of the thigh or above. But stents below the knee generally don't do well, and they're only used in exceptional cases.
Right.
Because you have to understand, stent is ultimately metal, whether it is steel, nitinol, or cobalt. It is some kind of a metal, and metal is a foreign body.
Right.
And by the time the heart pumps, and by the time the blood comes down till the thigh or the knee, the pressure of the blood would have reduced. So it doesn't go with that kind of force, it goes through a cardiac stent. So repeat deposition of cholesterol and other bad substances are higher.
Right.
So always, the one thing which is uniformly known anywhere in the world in the last 50 years as per researchers, natural disease in the blood vessel, natural disease progression of a atherosclerotic cholesterol plaque or whatever is slower and lesser than stent disease progression. When a stent blocks off, the disease progression is much faster and is much more difficult to treat. So especially in the lower limbs, stenting definitely has a big role, but in selected cases only.
Great. So it's very important to know this difference, because normally patients might come back and ask that, it is just a block, why don't you just stent it, and then, probably I will get better. That is the usual consensus that most patients would have, right?
Very common. See, when we do angiogram, angioplasty, and then call the patient to the cath lab console and show him, see, this was the block, we passed the wire, we put the balloon, this is the end result. Their default question, because of the mindset, is, why don't you put a stent? I didn't say, no, I have the money, I have the insurance, put a stent. We spend more time telling them why you should not put the stent rather than about the good result we achieved.
Yeah.
So it's a mindset change.
Yeah.
So like I said, as more awareness goes, people realize.
Right. And the next thing I have is that the calf muscle is known as the blood pump in your lower body. It is also known as the peripheral heart of the body. Why is that so, and why so much importance on the calf muscles?
The calf muscles are related to the venous part of the vascular system, the veins, the deep vein thrombosis, etc., etc. The first thing I think people should realize is, all normal human beings, 60 to 80% of the blood which is circulating in the blood vessels of the body are in the veins. It's only 20 to 30% which is in the arteries. So the veins carry almost 60 to 80% of the blood in the body. And then you have very few storage reservoirs which can pump. And the calf has a huge storage capacity, because inside the calf, it is not just the veins. You have what are known as sinusoids, which are inside the muscles. So between the muscle fibers, you have sinusoids, and they also can carry and store a huge amount of blood. So if blood which is there is stagnant, it is very, very dangerous. It's like a time bomb. So blood by default should always be flowing. And where should it be flowing the most? In the area where it is stored the most. So when you have the second heart, which is the calf muscle, which is a big reservoir, your job is to make sure that reservoir is not stagnant. It's continuously emptied and refilled.
Right.
So that is why the calf is so important, and activating the calf and making sure the calf keeps pumping, pushing that stored blood out and letting the new venous blood come in is so important. And if you don't do that, you are going to affect the whole venous system, and your risks of blood clots, life-threatening problems, all of them increase proportionately. So that is why when there's a simple organ called the calf muscle, which can be activated in a very, very simple way, even by sitting. If you're not doing that, you can have disastrous complications. And because it's so simple, we say it is so important to focus on that.
Right. I love how you call the calf an organ because I think not many people understand what is the importance of a calf muscle. Normally, when we tell patients that you actually have to do small, simple things while you're sitting, just lift your toes up and down, and that's more than enough to keep your calf muscles active. And we see so oftenly women mostly present to us with no calf muscles at all. It is just a belly of fat that is there. So I think this is more so important for everyone, whether they're standing, whether they're sitting, just doing simple things like you said, like, lifting their toes up and down when whatever activities they're doing makes a huge difference in their vascular health.
Perfectly agree. I mean, unlike other diseases where you have to do a lot of difficult things,
Yeah.
here in this disease, you have an option of doing the simplest things which even the laziest person can do.
Yeah.
And the other thing with the calf muscle is if you don't use it, especially in old people, what happens is slowly it's not about the calf muscle. The muscles below the calf and the tendons which connect to the ankle, you start developing ankle stiffness. Once you start developing ankle stiffness, especially if you're old, if you're a lady and you're a diabetic, after that you realize and you say you want to do it, it is not effective because your ankle has already become stiff. So even after that you start walking, you do that, the effectiveness of the exercise comes down significantly. So that's why we say before ankle stiffness sets in old people, keep doing all these.
Right.
So that is why it makes a huge difference in prevention for the next decade.
Right. The next thing that we commonly hear is that why are there some diabetics who are losing their foot and developing ulcers early on compared to some of them not developing it?
Because diabetic foot is basically when things go bad, it's either in isolation or in combination of three factors: a vascular component, neurological component, and infective component. Most people, it is a combination of the three. So if you had the infection, you treat the infection, but you have missed out on the vascular component. It doesn't matter how much you have cleared out the infection, how much ever antibiotics you give. Ultimately, the antibiotics have to be carried to that area and the road is not proper. So those people, even though you have done some local treatment at your center, the infection will spread rapidly. Second thing is gangrene because of ischemia. Vascular is very, very commonly missed out. And if that is delayed, diagnosis and treatment, infection rapidly spreads and it goes on.
Right.
So people in whom it is multi-system involvement, they deteriorate rapidly. If your diabetic ulcer is mainly neuropathic with less of infection and zero vascular involvement, those people rarely deteriorate fast. Sometimes they have their ulcers called as trophic ulcers for years and years and years. But people with vascular or infective, then things can go wrong. If it goes wrong, bad, it will be very bad, very fast, and they end up with amputations within days also.
Right. So it's just not the sugar levels, but it's about inflammation, it's about the nerve health, the blood flow, and which means that care, nutrition, and also proper cleaning of the feet and observing that, whether or not we have any ulcers, whether or not there is some kind of small infection that is there.
Very, very important, because diabetic foot, the biggest drawback in people with diabetic foot is almost 70% of them will develop neuropathy if they have diabetes for at least a decade or two. So when you have diabetes, you will have decreased sensation. So when you have decreased sensation, you won't realize what's going wrong with your foot. So what we tell them is, you will have to look at your foot like a baby's foot, like how you take care of a kid's body. So you have to spend, it's called a 2-minute examination, which a patient should do daily. He should look at the foot using a mirror. He should look for cracks. He should look for what is known as hyperkeratosis, thickening of the skin, because all these things are precursors of ulceration in the future. So looking for calluses, looking for thickened skin, looking for any fissures, all that is very important. You do these small steps correctly, then you can save the foot.
Okay.
And the last point, which is probably missed the most in the Indian subcontext, is footwear.
Right.
Abroad, diabetic foot, the counseling is very strict. You have to have offloading diabetic footwear. Outside the house, you got to wear a pair inside the house. So even in the house, it is mandatory for you to wear diabetic footwear to reduce the pressure on the pressure points to prevent ulceration or thickening of the skin in the future. The problem in India is because of a cultural context and a religious context, it doesn't matter how many times you tell people, 90% refuse to wear
Footwear.
diabetic footwear in the house. And that also is a major contributing factor as you
Right.
grow older.
And I think there are very, very simple steps that can be life saving for diabetics. I think it's not like they have to do a host of things, which are difficult for them. As simple as cleaning their feet, looking after them, and wearing diabetic footwear is the most easiest thing that they can do today to actually prevent a lot of their
Yeah,
disease.
100%. Has to be done consistently.
Yeah, I think that's the most important.
Exactly.
Then following this, a lot of people develop ulcers, and I myself have seen it that they will do at-home remedies. They will do other homeopathic, Ayurvedic, and so many things. And suddenly the ulcer is just not healing. Then they come to the hospital wherein it is not skin deep, but it becomes a muscle deep ulcer. And eventually, sometimes we see bones being exposed. How should someone actually take care of their ulcer?
At home,
In general, once they see an ulcer, what should be their go-to?
again, I feel it comes down to a thinking process and awareness. The problem with diabetic ulcers is the main problem is it's like a silent killer. The sensation is less, the signs and symptoms are not very obvious. So they delay things. So this is standard way people approach things at home. Small ulcer, slight redness, let me wait and see, let me give some antibiotics, let me go to my doctor, let me trust. They don't realize that it's like the tip of the iceberg. If you're only seeing the tip, but by the time you take the tip seriously, the rest of the iceberg would have increased in size and the penetration downwards into the muscles, into the bones would have already happened. So the first and most important thing for the public is please be aware that because your symptoms are going to be very less, you're not going to have pain, you're able to walk, all that, you tend to neglect things and the hidden damage is already happening. So first thing is, if nothing is improving in 2 to 3 days, please get a proper opinion from a doctor because this is a silent killer. You will not realize how deep it has spread.
Right.
Youngsters, non-diabetics, if the same ulcer happens, they'll have so much of pain, they'll come to you running immediately. But senior citizens, diabetic patients, no sensation, very bad neuropathy, you can have 10 times the damage and they'll be happily walking around.
Right. And they also have this thing that it's very small, so nothing will happen. But what they don't realize, like you said, is a huge damage that's happening on the inside.
Exactly. So that is why I keep saying it is all about awareness, and it's a mental mindset among the senior citizens which needs to be changed.
Right.
And that will make a difference.
Right. The next thing I want to check with you is if you could compress your wisdom into 3 rules for a healthy blood vessel, what would that be?
I think the first one will be lifestyle changes. So I think, there's an overload of information available everywhere. So I think you should stick to the KISS policy. Keep it simple and stupid. When you can stand, don't sit. When you can walk, don't stand. If you have that mental awareness from a young age, not in your 50s and 60s, from especially in your mid 30s and 40s, that is the first step. It doesn't need any extra effort. It just needs presence of mind. So if you can do that, and the next step is making sure you exercise, at least you walk, at least an hour a day, exercise, some amount of strength training, that will suffice.
Right.
You don't need to go overboard and do something to the extreme. But I think here consistency is the key, especially in your mid 30s and 40s. So exercise makes a huge impact. Once you have confirmed vascular disease, then you have options like supervised exercise training. The problem what people, especially young diabetics, should realize is if you miss this 35 to 60 or 55 age group and then you realize
Mm.
and you already have diabetic complications like neuropathy, etc., and then you say I'm ready to exercise might worsen it
Yeah.
because you'll be putting too much pressure. So that is why, especially diabetics, it is in your 30s and 40s what you do will make an outcome for you in your 60s and 70s. So exercise in your 30s and 40s. In your 60s, it's got to be more of yoga, strength training, exercises where you're not putting too much
Pressure.
So that is why sometimes swimming is considered a good exercise.
Yeah.
For people of that age.
So next is that there are very simple things that people can do early on. Basically, what you said is to prevent disease. It doesn't have to be complex 500 things listening from 500 different influencers. It has to be simple things that you discuss with your doctor, simple things that your doctor recommends. Just follow it with one mantra, that is consistency.
Exactly. That is with exercise. The next thing is diet. Diet, again, I shouldn't be talking about it as a vascular surgeon because enough has been told about it. But again, my funda is the same. Eat in moderation. Eat in moderation. I mean, once you feel you're 80% full, stop eating. Keep that mantra. Eat properly. From a atherosclerosis point of view, the two things which a person should remember, what is now changing is it's all about inflammation. And they're talking about gut microbiomes and inflammation. So it's about your gut and diet. And also, one thing which is generally missed, especially among youngsters and from a lifestyle modification, is proper oral hygiene. Oral hygiene, periodontitis also has been clearly proven to be linked with atherosclerosis in old age. So in your younger age, proper gut hygiene, proper oral hygiene and looking after your gut, these two things also make a big impact in your old age.
Right.
That way. But I won't go into diet because that's a totally different ballgame.
Right. So I think it's very clear. It's just simple lifestyle modifications. Simple thing is consistently doing those things rather than saying that my grandfather did this and stayed up till 80. And rather than doing that, follow what is relevant today. Based on today's generation, based on today's stress levels, and see how that's making a change in your life, because now we have tests, we have biomarkers that can be looked after from time to time. So what are some of the biomarkers that we should look into in terms of vascular health?
I strongly believe, there are huge plethora of biomarkers, but I don't think all of them should be done. They should be done under the guidance of a specialist. But two tests which you have to do every 3 months are lipid profile and HR-CRP. One for your cholesterol levels, one for your inflammatory levels. Don't aim to get that to normal levels. Make sure month on month or every 3 months when you get it tested, it is showing a downward trend. If it's showing a downward trend, and you're doing your diet and lifestyle in moderation, I think that is more than enough. Right. But if you have other inbuilt risk factors, that means you're already a diabetic, you already have other issues, you already have genetic issues, you already have a strong family history, then you need to go down the lane of a proper inflammatory package or a lipid package, get the detailed tests and get detailed assessment and counseling.
Right. So moving forward, if you can share what was one of those moments in your career spanning 30 years that actually said, I am very happy for being at this place where I am today, and that gave you that satisfaction in your career.
Oh yeah, I'm very happy because when I joined, this was a new field. The rejections from patients, you want to do the correct thing, but because of patient awareness and public awareness and even awareness in the medical field, you couldn't do the right things.
Yeah.
And I used to see, hundreds of people going with their legs amputated or not even getting amputated. They'll go home and they say, we'll just pray to God, let him be with us for as long as possible. And now within 20 years, I see the shift. Now people are so much more well informed. They're looking at quality of life. They understand, and I'm able to save so many limbs and indirectly so many lives also, because you keep the vascular system under control, you indirectly improve the lifespan and the life quality of the patient. Right. So that way it's a huge blessing when you can heal so many old people in the last stages of their life. And in the thank you for saying, at least I'm independent, I'm happy for however long I live, I can
Right.
live independently. It gives you a lot of satisfaction. So I think that is something which I've seen happening. The second shift I've seen in my practice, which makes me happy, is initially it used to be only open surgeries 2-3 decades ago, which has a higher death rate, higher mortality, more suffering to the patient, difficult recovery. But now, majority of vascular work happening the world over is minimally invasive. So because it's minimally invasive, the risk to life is less for the patient. Recoveries are much faster. Patients are going back happier. So we're able to treat more patients, convince more patients, and indirectly, at the end of the day, more patients are walking back with proper legs, living a better quality of life, and much happier. So I think that also gives me a lot of satisfaction.
I think it is safe to say that you were one of those founding members of Jivas, the epitome of vascular care in Bangalore, which was set up, I think, 20, 30 years ago.
Yeah.
And you were one of those founding members. Back then, vascular surgery wasn't even known. It was a specialty that people didn't look forward to walk into. They just walked into for amputations or for similar smaller disease like ulcer and wound care. But today, I think, like you said, we are seeing it evolve into a space which is more than that, which is adding years to people's lives. And when you said the thing about today, we are saving limbs, that does not only mean people's longevity, but it also means they're able to be mobile, they're able to earn for themselves, and they're able to add to the country's economy rather than just becoming sick and morbid.
Hey, perfectly said. 100%. I totally agree. So that's why I keep saying it's now, at least for people in their 40s, they should be completely aware, they should become completely aware about vascular, because this generation in their 40s are actually going to be living much longer.
Right.
And they're going to be exposed to vascular for a much longer time than the present generation. So if they're aware now, their suffering 3 decades from now will be less.
Correct. So I think that rightly said, I think the 40s is a great decade for people to actually look into their vascular health, and it should be one of the most important decades where they look into their vascular health, because that's going to add another 30 years of non-sufferable life
Exactly.
to them, right?
Definitely.
So what I understood from today's episode of vascular health is that vascular health is something that's invisible and it just explodes at a time when nobody's expecting it. And Dr. Vishnu, you had given us simple habits, simple steps, and simple diagnostic events that one can actually do to take care of their vascular health. And if there's one thing to do after this episode, I think it would be just taking a 30-minute walk. Like you said, simple. Whenever you need to, whenever you feel that you don't need to sit, just stand up and walk. And whenever you feel the need to not sit, just stand up. I think those are simple steps one can take today, and your vessels are going to thank you for the next 30 years.
Exactly. Definitely.